I think now Vaishali is there. Yeah, please come. So Vaishali is going to present ab interno Schlemms canal viscodilation and trabeculotomy by Omni system in open angle glaucoma.
Okay. Good afternoon, everyone. I'm going to talk about the Omni surgical system, which is an MITS device which has been sort of developed by Sight Sciences to target 3 different sites of outflow restriction at the trabecular meshwork, at the Schlemms canal, and at the distal collector channels. It is a device that can perform ab interno circumferential canaloplasty and trabeculotomy with a single handheld system. We are presenting here the retrospective analysis of the first 30 eyes that were performed at our center between August and December 2022 by a single surgeon. A target IOP was set for each eye preoperatively. Blood thinning agents were not discontinued preoperatively. The postoperative follow-up visits were at day 1, 1 week, 1 month, and every 3 months thereafter. All the anti-glaucoma agents were stopped after the surgery, and if they were reintroduced one by one if needed, if the intraocular pressure was not satisfactory for the stage of the glaucoma at the other visits. The case notes were then compared for pre and post-op vision, pre and post-op intraocular pressures, pre and post-operative number of medications at each visit. Any complications were also noted at each visit. Now, of the 30 eyes, 11 eyes underwent standalone canaloplasty and trabeculotomy, which we will call Omni for simplicity's sake, while 19 eyes underwent canaloplasty with trabeculotomy combined with cataract surgery, which we'll call phaco Omni. For the purpose of this review, complete success was defined as any eye that reached the target intraocular pressure without any anti-glaucoma medications. Qualified success was defined as any eye that did the same with anti-glaucoma medications. And failure was defined as any eye in which the intraocular pressure could not be controlled or it needed some other surgical intervention. So this is the demographic data for our 2 groups. Most of the patients were in the 7th decade of their life. The age range was quite similar in both groups. Males were more common on both groups. The group A had the more severe glaucoma. It also had more average pre-op medications, and it also had more pre-op glaucoma surgeries before the Omni was tried on compared to group B. Primary open-angle glaucoma was the most common diagnosis between the 2 groups, followed by secondary open-angle glaucomas and ocular hypertensions. We also had some normal tension glaucomas and some angle closure glaucomas, but they were very little. The mean baseline intraocular pressures in group A was 22 millimeters of mercury, which reduced to 13.37 millimeters of mercury at 12 months. The same baseline pressure for the group B was 18.31, which reduced to 13 millimeters at 12 months. There was a significant reduction in the number of medications in group A from 3.5 at baseline to 1.27 at 12 months. Similarly, for group B, there was a significant reduction from 2.8 at baseline to 0.5. So 1 eye out of the 19 eyes was on medication at 12 months. All of the eyes bled a little intraoperatively, but only about 3 eyes in standalone canaloplasty and trabeculotomy, and about 10 eyes in the combined group had blood clots in AC on day 1. Layered hyphema, less than 2 millimeters, was present in 7 eyes, which resolved on its own without leaving any sequelae or needing any active intervention. Intraocular pressure spike more than 10 millimeters of mercury from baseline was seen in 2 eyes, was managed conservatively. No eye suffered any visual loss, which could be attributed to the procedure itself. So success rates at the end of 12 months was 39% reduction from baseline in standalone Omni group and a 29% reduction in the combined group. 1 eye needed polyglaukoma implant, so it failed in the standalone group. So this is just a comparison of the cataract with the Omni group because this was more comprehensive. We found 2 other studies. The Gemini study, which was a prospective study for canaloplasty and trabeculotomy with cataract surgery, and Habash et al., which have presented their 12-month outcomes of combined GAT with ABIC, which is sort of with cataract surgery, which is something similar to what the Omni does, but not exactly the same. Intraocular pressures and other success rates were comparable, but we had less people in the more than 20% reduction group, and that's possibly because we had a lot of ocular hypertensions and normal tension glaucoma groups. Limitations of our study are retrospective analysis and loss of data at 12 months. However, it does show us that combining canaloplasty with trabeculectomy and cataract surgery could be a good management strategy for mild to moderate glaucoma. It could still be offered for patients with advanced glaucoma because it has less risk and less surgical time is needed to do it, and it does cause a reduction in the medication load. But obviously, better studies with more follow-up and with more number of patients are needed to validate these outcomes. Thank you. And that's the clinic that we were.
Thank you. So
Thank you,
how did
Dr.
set-
Vaishali. I just wanted
Sorry.
to know, was there any subgroup analysis done with respect to the different types of glaucomas?
There were very few patients in
Yeah.
each, madam. So there was just one angle or one NTG. So
Yeah, but
it wasn't really-
overall, any clinical difference that you found, especially with regards to pseudo exfoliation?
Again, there were only 2 patients,
Yeah.
so we have not
No
made
com-
any
no
this thing, but it was
comparison.
sort of generalized.
Okay.
Yeah.
How did you set the target IOP?
It was based on the age of the patient, the visual field index, how much was the glaucoma, what was their life, this thing. So based on that, we set up a target IOP.
No absolute number.
I'm sorry.
Yeah.
No absolute number. So this was a retrospective study. So we just started doing the surgeries, and for each patient, as we do, we expect it to go to a certain level. For halting the progression of glaucoma or reducing the progression. So that was how it was done. And then we just thought, okay, let's see what's happening in our center with the first 30 patients at least, how are we getting on with it. So that was just it. So there was no fixed reduction or anything. The data that I showed was just because the other studies have said those parameters, less than 18 millimeters of mercury or more than 20% reduction. So that was just to compare with, to see how our data fared with those studies. But no number was set before. It's
So-
a retrospective study now.
A lot of patients developed hyphema,
Yes.
but the vision did not drop.
No. I mean,
Not
the
on
vision
the first day.
fluctuated in that period, but there was no sequelae afterwards. It just, sometimes you have a clot, or you sometimes have dispersed hyphema, but that resolves on its own. So by 4 to 6 weeks, there's nothing there.
But initially in the first week, you're saying hyphema is there and vision may
Mm.
have reduced, fluctuated.
Yeah, just fluctuation. I mean, no significant loss of it, no irreversible loss of vision, which could be attributed to the procedure.
So do you think these antiplatelets could have been stopped or?
We didn't really have a problem at 4 to 6 weeks, and even at 12 weeks, there's nothing really there. So they could have those antiplatelets for some other, bodily problems, which could be more severe than their glaucoma. So, I think we got away with it so far. But yes, that should be kept in mind that they could bleed a lot. One of those could be, quite.
So we have
yes.
to tell the patients before the surgery.
Yes,
that
we
this
do
may
tell
happen.
them that, this is something that is cutting it from inside, so do expect some bleeding. And of course, if they're on blood thinners, we do sort of tell them that that's what's going to happen.
Thank you.
So proper counseling
You had
is
no incidence of secondary hemorrhage, like you saw the blood come immediately post-operative day, some clots were there and they disappeared. But did you have a patient who had no blood on first
No.
and second post-operative day,
No.
bled later?
No.
Okay. Thank you, Dr. Vaishali.